Good afternoon, everyone. I thank Dr. Neeraj Sanduja, Dr. Ajay, and my co-instructors for this invitation. So I'll straight away, Dr. Ajay has partly covered these studies, so made my job much easier. I'll just go through them real fast. So DCCT was a trial which was a prospective randomized trial to evaluate effects of tight metabolic control on the development of retinopathy and the progression of retinopathy. And it does not address the issue of tight control in patients with non-insulin dependent diabetes. So these were the results. At least 3 years of intensive treatment was required before beneficial effects on diabetic retinopathy were evident. In intensively treated group, risk of onset of diabetic retinopathy was decreased by 76%, risk of progression of diabetic retinopathy was decreased by 63%, and risk of development of CSME by 23%, and the need for laser treatment by 56% compared to the conventional group. And this benefit persisted even 4 years after initiation of intensive therapy. So there was a decreased incidence of microalbuminuria, albuminuria and clinical neuropathy, and 2 to 3-fold increase in hypoglycemic events. So this was like a downside. So further, DCCT highlighted that after initiation of intensive insulin therapy, there may be an initial transient worsening. However, eventually these patients fare much better in the long run. UK PDS was another study. It was a 20-year trial, and the questions asked for that does improved glucose control prevent diabetic complications in type 2 diabetics, and does therapy with sulfonylurea, insulin or metformin has any specific advantage or disadvantage. The results were that the intensive therapy to reduce glycemia decreased the risk of complications, and here a target glycosylated hemoglobin level of 7% was desirable. Tight BP control reduced the risk of complications and is as important as tight glycemic control in diabetic hypertensive patients. There are no major differences between the therapies tested, and decrease in LDL decreased the cardiovascular disease, and cardiovascular disease was 2 to 4 times higher in type 2 diabetic patients, and low dose aspirin was also useful, and patients were encouraged and counseled to stop smoking. So we've already seen this, that the tight control of BP was useful. So some of the other risk factors, another study was the Wisconsin study, which showed that diastolic BP was an important factor in the progression of diabetic retinopathy and occurrence of PDR among young patients with insulin dependent diabetes mellitus. Another study, the same study has also shown a link between glycosylated hemoglobin and DR progression. Other studies have reported direct relation of higher levels of glycosylated hemoglobin with persistent CSME, so all those recalcitrant cases, and inadequate response of the proliferative retinopathy to PDR. ETDRS identified increased serum cholesterol and LDL as independent risk factors for development of hard exudates, which is a major risk factor leading to subfoveal fibrosis, and the beneficial role of statins such as atorvastatin has also been shown in studies. Anemia has been found to be an independent risk factor for the development of high-risk PDR, and beneficial effect of anemia treatment has been seen in DR patients. So the Wisconsin study, it also showed that there was an effective relationship between body weight and diabetic retinopathy for patients diagnosed less than 10 years earlier. Various studies have reported a relationship between proteinuria and retinopathy, and the presence and severity of diabetic retinopathy is an indicator of the risk of gross proteinuria, and conversely proteinuria predicts the presence of PDR. A beneficial effect of ACE inhibitors and angiotensin receptor antagonists on both proteinuria and DR, even in normotensive patients, has been shown. A few studies have reported a beneficial effect of dialysis and renal transplant on diabetic retinopathy, with improved stabilization and response of retinopathy to laser treatment. EuroDive was another study which reported a strong association between diabetic retinopathy and cardiovascular disease, and the severity of diabetic retinopathy was related to the incidence of heart infarct and stroke. Also, carotid disease has also been associated with diabetic retinopathy, and patients undergoing coronary artery bypass, the prognosis was much worse in those with advanced diabetic retinopathy. So optical metabolic control of all the above factors led to significant reduction in macular thickness and a trend towards visual improvement after 6 weeks, even without focal laser photocoagulation. This was one of the conclusions of a study. Possible therapeutic role of calcium. Several uncontrolled studies have suggested that calcium dobisalate decreases the progression of DR. Another prospective controlled study found no difference. The orally administered PKC beta isoform selective inhibitor ruboxystorin in subjects with moderately severe to very severe NPDR was well tolerated and decreased the risk of visual loss but did not prevent DR progression, and the treatment was associated with a reduction of retinal vascular leakage in eyes with DME. Aldose reductase inhibitors such as sorbenil and others have shown decrease in capillary cell death, microaneurysm count and fluorescein leakage. However, clinical trials had little therapeutic success. Trials with long-acting octreotide, somatostatin analog and growth hormone delayed the time to progression of retinopathy but had no effect on visual acuity or progression to macular edema. COX-2 inhibitors have also been tried and have shown prevention of neovascularization in experimental conditions. Human trials are still underway. ACE inhibitors, I already told you, they apart from the hypotensive effect increase both VEGF and corresponding receptor expression, and in experimental models ACE inhibitors have been shown to inhibit VEGF expression. Clinically, the results of ACE inhibitors, however, have been variable. Amongst the angiotensin receptor blockers, in a small study, losartan was shown to have no beneficial effect on diabetic macular edema. This is a very important point. In patients with diabetic macular edema, we must ask the physicians if they have been on pioglitazones, because pioglitazones, they worsen the macular edema, diffuse macular edema. So they should be substituted with other class of drugs. This is another interesting thing which I found, that there is a mention in a study that there is a possibility of worsening of diabetes control following bilateral laser therapy due to the disturbance of normal circadian rhythm, which results in nocturnal hypercortisolemia. So that was something very interesting which I found on review of literature. This is to just end my talk. I will just be showing you a case which just kind of highlights the importance of metabolic control. This was a case of PDR, status post PRP elsewhere with residual NVD, NVE and macular edema. The OCT showed cystoid component with the serous elevation, which Dr. Ajay was pointing out. Patient was advised diabetes control, dyslipidemia treatment, and was treated at that point of time with the posterior subtenance tricort with macular grid laser and fill in PRP. But you can see the macular edema just increased, and he was further advised the anti-VEGF injection at that point of time, followed by laser. And you can see the anti-VEGF injection did benefit him, his vision stabilized. But again, during follow-up the macular edema increased, and again the same Avastin was advised, but patient was not willing, and was subsequently followed. The macular edema worsened and still worsened, and lo and behold, he was diagnosed to have gross nephropathy, at that point of time. So these patients, they really tend to do much worse, and unless their the systemic parameters are controlled, especially the nephropathy part, because macular edema is very closely related to the the kidney function. So this is just a follow-up, and how eventually the patient kind of stabilized after, and he was eventually put on dialysis. So this was just to highlight the importance of metabolic control, especially the nephropathy in these patients with recalcitrant macular edema. Thank you.